Okay, good morning. We are set to start our webinar this morning. Excuse me, I just wanted to make sure we were recorded. I appreciate everyone in attendance and very much appreciate our speaker today, Christy Musser. We have given folks who have maybe moving between two meetings a couple of minutes to get settled back, and we may have more join as time goes on, but we do record this webinar and all of our webinars. So if you want to replay it or pass it on to someone else, that link will be on our website within probably about 36 to 48 hours after we do this, this webinar today. So as you know, we do this monthly webinar, and today we'll be doing a webinar on virtual care compliance, regulation, changes in the air. We'll also talk a little bit about reimbursement. There are some codes that Christy will reference as well and how they relate to some of the compliance and regulation pieces. So I'm honored to have Christy, who is known among her colleagues for her passion and leadership. As you can see here, she's an agent of change. Her recent focus has been in digital transformation efforts to improve clinical communications within the care team and leverage technology to connect patients to the right care and the right person at the right place and time. Notably, Christy has led the University Health Network through a culture transition from pagers to direct, secure, collaborative messaging, and then in the wake of COVID, led teams charged with the oversight or overnight pilot of 300 ambulatory sites to virtual care and implementing workflows to efficiently capture revenue. This is something that we know lots and lots of organizations have been doing, but not at the scale that Christy has been doing. The efforts resulted in patient retention of over 30% above industry benchmarks during the COVID-19 peaks. We're honored to have Christy here today to present this content. I am also on the line, and there's a small bio about myself, but who's important is Christy. So what I will do is turn over the controls to you, Christy, and you will be able to ship the slides. You should be able to do that yourself now. Thank you for being here, Christy.
Thank you, Michelle. That was a wonderful introduction, and I am very excited to be here today to talk about something that I think we've all been living the past year. We've been probably immersed in, and now it's, as things are maybe settling down a little bit, it's time to talk about where we were, what happened, and where we're going. And I'm sorry, I'm looking for, there we go. Okay. So a lot of information today, and I'm going to go through this information quite fast. I want to make sure that we get through it all. It's packed, and we can talk about questions either throughout the presentation or after. So really what we're going to go through today is, let's just get an understanding of who regulates telehealth, get some historical perspective around the evolution of telehealth in our health system, look at some core areas of regulation and legislation. What is the past? What's the present? What's the future in each area? Look at some basic compliance mitigation recommendations. And then we're going to wrap it up with some key takeaways and a library of up-to-date resources so that you can do your own ongoing tracking. So who regulates telehealth? It's really not much different than who regulates our in-person care services. So you have the federal, state, and private payers. What I want to mention here, and something that I've learned over this past year, is that on the federal level, things such as geographic limitations and originating sites and place of service, that all actually has to go through Congress and be passed by a bill. At that level, Centers for Medicare and Medicaid, CMS, has a say with reimbursements and the certain services that they will cover, but two different governing bodies there, often collaborating together. Okay. So really want to just get a broad picture here of where we've been. So 10, 15 years ago, I think there was maybe a little telehealth.
Sorry, Christy, I think you're having trouble advancing the slides.
I am. I'm sorry.
No, it's okay. Let's fix that. Just a second. Let me see if we can fix that really quickly. I think I allowed you to be the host, so I'm not sure if you've accepted that.
It did tell me I was the host.
Sorry about that.
I just sent a request for remote control. Maybe that will work.
No, perfect.
Okay, all right. I'm sorry, everyone.
No,
So,
that's
so you can see here that, in the past 10 to 15 years, we have moved the needle with telehealth, but it's been pretty slow going. The drivers of that change has been the value-based reimbursement models that we've started to dip our toes in, some consumer-driven healthcare, and of course, EMR technology and advancement. But as you can see, 10 to 15 years, some progress, not very fast. And then overnight, and it went backwards. So now we're back to the first 10 to 15 years. And there we go. At the speed of light, we went almost to the point of everything goes, not quite to the Wild West, but we're getting there. And that was in a 3 to 6 month time period. And what was the driver of that? Simply the pandemic. So we know almost everything goes now, right? A lot of things are just, people are just doing what they need to do to provide healthcare. So where are we going to go in the next 3 to 5 years as things start to level out? I think we're going to balance, we're going to start to balance. And what's going to drive that is the patient provider satisfaction, regulation change, and a proven positive impact on cost and quality and access during this time when we've been allowed to just kind of carte blanche provide telehealth and receive reimbursement. We're going to see this happen over the next 1 to 3 years, I believe. But as you see, this did not go back to where we were. It's here to stay. We don't exactly know what it's going to look like, but we do know it's here to stay in some form or fashion. So core regulation areas, we're going to look at briefly some reimbursement, licensure, down to prescribing consent, partnership arrangements, and security and privacy. So reimbursement, we're going to take this on each slide, very just going over a brief view of what it would look like pre-pandemic, pandemic, and what's the future going to look like. So pre-pandemic with reimbursement, there was inconsistent fee-for-service reimbursement, geographic restrictions, originating site limitations, just very spotty coverage and inability to do telehealth and be reimbursed for it. And without the full full switch into value-based reimbursement, it was challenging to really render telehealth at full scale. So the pandemic hit in March, and actually we're at the year anniversary now. Parity coverage across the nation, pretty much, within a few days, we saw that happen. I'm sure all of you experienced that in some form or fashion. With additional services covered, the geographic restrictions lifted, we can see that the patients in the home, FQHCs, RHCs, all able to do what they need to do. But where are we going to go from here? We don't know. And this is where some of the legislation at the federal level and payers, private payers, need to start looking at their internal policies and our bills and regulation. So what we hope to see is removal of geographic restrictions for some or even all telehealth services, expanding those originating sites, permanent coverage of additional services, which we already are starting to see happen. Maybe even some audio only coverage, which I didn't think was going to go over past the pandemic, but it looks like maybe we're going in that direction. And the waiver of how telehealth services will be paid. So on the discussion of reimbursement, I did want to mention this subgroup of services called communication technology-based services that was not a well-known group of services prior to COVID. But what I want to point out is that they complement in-person or telemedicine delivered care. And they were actually reimbursed by CMS and many payers prior to the pandemic. And we don't expect that that's going to go away. And they are not necessarily subject to all the guidelines that parity telemedicine services are subject to, such as the geographic restrictions and originating sites. But there are certain guidelines that you'll see here. Here's all the codes My screen is now kind of moving on its own.
I'm sorry, Christy, that was me. I apologize. Please keep going. We're remote controlled, so if I move, then it moves with you.
It moves, okay.
And I didn't realize that. I apologize.
No, it's okay. All of us getting used to technology, right? So general guidelines, you'll see here, I'm not going to go through them, but there are some other guidelines, even though they don't follow necessarily the things we're talking about today. Here's a list of what communication technology-based services are. So you've got your triage audio only services, and they actually added to that an additional code with additional time. Asynchronous visits, or the e-visit portal visits, where you communicate via technology and not even have audio video connection potentially. Interprofessional or provider to provider consults, and remote physiological and remote patient monitoring. So those all fall under this umbrella of communication technology-based services. So as you look at codes and reimbursement, remember that this is a little carve out of services that you should keep an eye on as to what's evolving there.
So Christy, I'm just gonna jump in on that slide because I wanted to talk to you about the interesting element of that being computer-based technology services. And I think that what we're seeing, and I think you and I certainly have talked about this in the past and information for others, is what's interesting about this is CMS's carve out of this as a CTBS rather than defining it as telehealth, where remote physiological monitoring, or what we would commonly call remote patient monitoring, would typically be under the telehealth umbrella. They've sort of carved it out. So it's interesting. I wonder if there'll be more like that. What are your thoughts?
I think that we're going to start seeing that, and the indication that that may happen is even the addition of a new e-check-in code in January, and the expansion of codes to the non-qualified healthcare professionals, such as physical therapists, who can start now to bill for these services. So I do think we're going to see this remote patient monitoring, given that these codes are fairly new. I think we're going to see an evolution there as well and see some broader monitoring overall.
Yep, I agree. Thank you.
Sure. So then we move on to licensure. Pre-pandemic, pretty much 50 states, 50 approaches governed at the state level. The originating site where the patient is located needed to be the place when they were physically having the telemedicine service. Where the patient was located needs to be the place where the provider was actually. So if you are in California and you are seeing a patient in Oklahoma and you are not licensed in Oklahoma, that would have not been considered appropriate. There had been some progress in starting to expand that through the Interstate Medical Licensure Compact, and the Veterans Administration actually moved to full interstate coverage with their providers in 2018. So we're going to see a pattern here. The pandemic happens, and cross coverage across the nation happened pretty fast at the federal level. And some states issued, and currently there's 43 states that have issued emergency waivers that include licensure. Now, what's interesting is state by state, there's some variation in what they're allowing. Some are allowing border states, some are allowing only for COVID purposes, and some are allowing full carte blanche, just to help take care of patients. So it's important to know that even during this pandemic time, where everything kind of goes, is to make sure if you are treating patients outside of the state you are licensed in, that all boxes are checked. And also during this time, the number of states participating in the Interstate Medical Licensure Compact has increased. So where are we going? I really, in talking and socializing with many different colleagues, I think the federal government may get some traction to redefine the place of service, where the telemedicine is the location of the place of service, telemedicine is the location of the physician versus the patient. I think this has already been discussed, and it did not go through, but I think we may get some traction there. Also, expansion of that interstate licensure compact for physicians, nurses, nurse practitioners, physician assistants, all across the board. I think we're going to see that happen. So clinician-patient relationships and approved providers, pre-pandemic, a lot of variation on interpretation, really some limitations. Most people went with the telemedicine is not the appropriate vehicle to start a patient-provider relationship, meaning you had to have an in-person relationship prior to providing a telemedicine service. Some states remain silent. And also there was limited licensed providers who were able to render telehealth services under their scope. Pandemic happens. Anything goes now. You can see things that, you know, was established patients only is now open to any new patient for almost any service. And most states are allowing for an appropriate telehealth visit utilizing audiovisual. Real-time communication is acceptable and ethical way to establish a provider-patient relationship. We've also started to receive more clarity around the guidelines of establishing a relationship via telehealth and what that's going to look like. And some expansion of providers allowed to bill for telehealth, as we previously mentioned. So what does the future hold? And again, these are not actual, you know, this is all speculation, but hopefully informed speculation of where we're going based on trends. But hopefully we're going to see some improved definitions and parameters spelled out around the patient-provider relationship and how that is started. More flexibility to use telehealth as a vehicle for establishing that relationship. And guidelines may differ by service. So for example, telepsych services have actually permanently been expanded. Geographic restrictions have been lifted. Providing in the home for many services is going to be allowed permanently. That's set in stone. But the caveat there is that in the new areas that it's allowed, right? If it's outside of a previously geographic restricted area, then you have to have a requirement of at least one in-person visit within the past 6 months where the telemedicine visit occurs. So it's going to be interesting to see as this goes out, what services require what and where and how. But I do hope that we're going to get some more defined parameters.
Christy, this is Michelle. Tell me what your thoughts are on the expansion at the state level for nurse practitioners to be able to do more and more under their licensure. I'm seeing some states where there isn't even an oversight by a physician at this stage. And in some states, like my state of South Carolina, we're still very much restricted with the mileage space. So for example, a physician has to be within 100 miles of the nurse practitioner, which is often very controversial because in a lot of cases, like in my state of South Carolina, the barrier islands, for example, their nurse practitioners handling patients out there. And it's really sort of almost a farce that there's a physician within 100 miles, because in some cases, they're not even seeing those patients, nor the nurse practitioner. So my question to you is, what do you think about individual states and their progression towards allowing nurse practitioners to work more towards the top of their licensure, and whether or not you think the AMA will allow that in the scheme of telehealth?
So that is a great question, and I don't want to step into a hornet's nest here with my answer, but
it's opinion, yeah.
So I'm going to try to answer, from an objective perspective. It is controversial, but I do see the advancement of all advanced practitioners moving forward. And I know that there are physicians who are legitimately concerned, and I think those concerns need to be addressed, but I don't see it not moving forward, and really because of the lack of resources that we have to provide services overall. These advanced practitioners are really filling in a lot of the gaps that need to be filled in. Now, with that, I'm sure there will be increased, guidelines and oversight, and maybe even education, as we see with our nurse practitioners. They now are, have advanced over the past few years into that doctorate level. So with the advancement of their ability to independently see and treat patients, I think also their education and oversight specifically of them will increase as well.
Thank you.
So prescribing. So this is an area that was actually a hot topic before COVID with e-prescribing. But like most things, clinicians were required to hold an active DEA registration in the state that the prescription was issued. There had to be an established patient-provider relationship for any prescribing that occurred. And whether or not that was able to be established via telemedicine was, depending on where you were or the interpretation could be different. The pandemic, the DEA made the exception that you could prescribe drugs through telemedicine, and there was, based on the controlled substances and the what the drug type, there's some different oversights there, but they did open that up. So what do we see moving forward? I really expect this is going to be one area that's going to go back to some tighter control because, we have another epidemic happening, in America with our controlled substances, and we don't want to lose ground on the progress we've made there. So I think we're going to go back on that, but there may be some increase of states allowing telemedicine as a vehicle for establishing relationships and then to prescribe. And also, I have not necessarily seen that this was out there, but maybe there's a potential for an interstate DEA registration compact where it would make it easier for providers to get a DEA registration in multiple states through a streamlined process. So something to watch for there. Consent. So pre-pandemic, there was actually a lot of work going on around consent for telehealth, and consent requirements actually tripled for Medicaid payers between 2013 and 2017, but they were all over the board. Again, 50 states, 50 approaches. Some, it was allowed just in the general consent. Some had a very specific information you had to have in the consent, and it had to be separate, and some states were silent. Medicare pre-pandemic did not require any sort of informed consent. Pandemic happened. Well, it was basically, okay, you get them on the phone or on the video and you're providing a service, we're going to ask you while you're there and get it verbally and document that, and that was acceptable. There has been an increase of explicit requirements for consent by each state. So there's a lot of thought now going into, okay, what are we going to require going forward? What are we going to see? I hope we see an evolution of best practice for consent and awareness. Now, so not only consent, right? One of the things that I've talked about with multiple colleagues is, does anyone ever read the? So it's more of an awareness and letting patients know their rights around the services that they're receiving. But I do think we'll continue to see increase of states outlining their permanent consent requirements and guidance as to timing and the information that needs to be included in a consent. So that was just a very quick overview of a few core areas. Privacy and security is one area that I wanted to spend maybe just a little bit more time on because it is very important. And I think this next slide captures it in one sentence. When people's health and personal data are involved, the stakes are high for getting it right. So we're adding in, a technology platform here that adds a whole new level of potential breaches. So we do really need to pay attention. HIPAA and HITECH, I'm sure everyone on this call is aware of these laws. They were put in place to protect disclosure of PHI and an individual's right to control the use of their PHI. And then evolving legislation with HITECH was used to actually enforce HIPAA legislation. So HIPAA specific to telehealth, and this is one where I'm not going to go through maybe a pre, post, or pre, current, and post, but we're just going to look at this overall. So people, platform, process. Under HIPAA, people, only authorized users should have access to EPHI, no different than an in-person service. Only it may be a little bit harder to control that. So some risk that is there, and analysis that has to be done. The platform, a system of secure communication should be implemented to protect the integrity of the EPHI. We have been, again, in the Wild West. The OCR and HHS said we will not audit anyone during this time. You can use some of these platforms, the FaceTime, Google Duo, so on and so forth. My personal recommendation would not be to get used to that. I do think this is an area we are going to see a pullback on, back to our normal state, almost, probably. And if anything, I would, if you oversee anyone who is doing telehealth, is to start to rein them in now if they've been using non-HIPAA secure or compliant platforms, because we are going to need to get back to that. So the process, there needs to be a system of monitoring those communications, because now we're going through channels that it's hard to see. We don't know what's happening in those channels, and it's in those channels that things are getting intercepted and then picked up and used inappropriately. So I wanted to bring up a specific one that I saw that I thought was interesting, and most interesting because of how it was, how the person said that they actually, what happened. So in the UK, a patient reported through Twitter, welcome to, today's world, that he was able to see 50 videos of other patient appointments while using the app. So although not subject to United States HIPAA rules, under UK laws, that app could be fined up to 4% of its yearly turnover, and the affected patients may be entitled to some claim compensation. HIPAA compliance best practices, this really fits into a compliance plan. What I want to point out here is that not only do you need, HIPAA needs to be part of your compliance plan. When you start working with vendors for telehealth, and those vendors are working with vendors, you have to ensure that not only you have an agreement with that vendor, with a business associate that's in place, but that their vendors have the appropriate business associate agreements in place with those that they subcontract to. So it's really important, because you will see some of the cases that have come out, it's a domino effect, that something may have happened, a breach may have happened in one organization, but it impacted all the platforms that were involved in it. They were all implicated.
I have a story to share there, Christy, because I think this is applicable, especially the example that you said about health systems or folks that are purchasing systems and knowing whether or not their partners have BAAs, and that their partners are complying with those BAAs. We have recently had a client who had a third party managing their credit card processes, and that credit card that organization that was managing their credit card processing accessed patient information, or accessed the patient information enough for it to be considered a breach, and that was done by a third party. We advised the health organization to report that to HHS. We asked the other company to come with them to HHS to report that, and report that over to, I think it was also reported to OCR as well, if I remember correctly. But they would not come. They did not think that they had a breach, even though the original organization did think that there was a breach. So the health organization went forward, said there was a possible breach, outlined the breach, and in fact, HHS appreciated the notification and said, we're done with you. We'll be talking to that other company. So definitely behooves you to be aware of BAAs and what your other partners are doing, and what they're doing with your information. And also, if you do suspect a breach or think that there was a breach, then to come forward with that as soon as possible. It is a benefit for your organization.
you brought up a great point, Michelle, in that example. And that is that going forward with information once you know a breach has occurred is critical. And as demonstrated, you're given a little bit more forgiveness going forward. There's a little bit more trust established there versus the company that did not go forward. So yeah, that was a great example. Thank you, Michelle. Here are just a few examples of health organizations and HIPAA fines that have occurred. A theme here is that there was a lack to do an enterprise-wide risk analysis or any risk analysis and then training for employees. So that risk assessment, don't skimp out on that. It's important because you need to understand where those vulnerabilities are, and to those who may not know the technology or what's happening, when people start talking IT to me, my eyes glaze over. So I don't know where the vulnerabilities are, and we really need to make sure that risk analysis is done thoroughly and documented. So that was, I'm hoping we hit home on the importance of that. Despite the pandemic, and despite some of the waivers and the flexibilities that we have been granted, cybersecurity is still critical and important, and will, I believe, continue to be a high level of focus. So now we're going to talk about arrangements, agreements, partnerships, reimbursements, and this really goes along with the law here, the Stark laws, the anti-kickback laws, the False Claim Act laws. So I'm sure most people are aware of these various laws, and really they, and I'm going to go back here for 1 minute. These laws have been put in place in what we have as our fee-for-service model in the nation, and they were really put to kind of check and balance that because things were kind of spiraling out of control there. So keep that in mind as we go forward, and I'll mention, I want to point something out as we move forward in that. I did want to point out that around this, they still are taking these things, around telehealth. What has happened is the DOJ recent operations. There's Operation Brace Yourself, started in April of 2019, and Operation 2020 Takedown, which started in September of 2020, which, if my math is correct, that is after the pandemic started, yes. So really the focus, though, was of how not necessarily the vendors of telemedicine, it's what happened via the route of telemedicine. So the activities that occurred during a telemedicine visit is what's being focused on here. So DME, prescriptions. So those are things that are really being looked at, and these operations are continuing, and they've recovered already quite a lot of money in fines and penalties. So that's something just to be aware of. And as of January, the office, the OIG, did add to their compliance work plan telehealth services. So they are going to start looking at telehealth services overall. And I am sure that as there is an uptick in billing for telehealth services, that they will continue to really put that as a focus. Now, with that said, there's a lot of things under these laws that under the fee-for-service environment were very necessary. The increased regulation was needed because there weren't other checks in place really for us to control that. But as we move over into value-based reimbursement, and I believe that the what happened with COVID, right, has actually opened our eyes to this a little bit more. But as we move to value-based, this laws that are in place are actually stifling what we need in innovation to be successful, because we need to do these partnerships. People who have never been at the table before are now sitting at the table together, and creating, partnerships that we would have never thought of. But sometimes they would have implicated the laws in some of the arrangements that are moving forward now. So it's been noted that there needs to be a decrease in relaxation in regulation, so that we can move forward in a value-based reimbursement model. Now, with that said, what is kind of signaling this is that they added some new exceptions, stark exceptions, and anti-kickback safe harbors. Care coordination arrangements, patient engagement and support safe harbor were two big things around that could include telehealth, value-based arrangements, with vendors, with telehealth companies. There's going to be a lot more flexibility within these new exceptions and safe harbors. And just the intention of the changes is pretty, this sums up, I think, what I've pretty much just, talked about, and that's that value-based arrangements improve quality of care and outcomes, and they want that these new exceptions to promote moving forward with innovative ways to deliver healthcare. So potential impacts of these changes to telehealth. It's going to allow more pathways for smaller organizations to tap into the larger ones and utilize technology platforms and programs, and allow greater flexibility for medical device companies and software platforms to provide in-kind, services that would have previously kicked off, would have violated the laws, to be able to join together and come up with solutions that improve quality but reduce cost. And innovation is really at the heart of that. So, there's a big push of innovative relationships. Some real world examples. A remote patient monitoring company can now pay for a clinical a staff member to help identify and onboard patients into a remote patient monitoring program. That would have not been looked upon favorably prior to this, but alone as there's quite a few regulations still within these exceptions that have to be followed, but it is allowing us to start going down that road. Also, a hospital engages physician to provide telestroke services, and then the hospital provides the necessary equipment and pays for the physician an hourly rate. Those two things in and of themselves may have implicated both laws, anti-kickback and Stark previously. These are just some quotes from industry experts just around overall legislation, and just making sure that we're doing our part, mitigation as far as avoiding even the appearance of having a relationship that's not appropriate. And it's interesting to note that the pharmaceutical and medical device industry, which is the big part of what we look at for telehealth, has continued to account for the largest recoveries within some of the actions that have been taken. So risk mitigation, how can we avoid some things that what we've just talked about, and telehealth overall, whether the changes are remain to be more flexible, and those changes that we're going to see pulled back on. It's really important. It comes down to the seven fundamental elements of an effective compliance program, written all over CMS, in making sure that your telehealth services and programs are included in your compliance plan. So we are at the key takeaways. And we've got a few here. So there are many levels of regulation around telehealth. So anyone on this call, and as you start to work with other colleagues, understand what pertains to you specifically in your organization from every level, the federal, state, and payer, and how they fit together and impact the services that you're providing. We're currently living under these flexibilities that are changing rapidly. So make a plan and keep a pulse. Don't let too much time go by. It used to be that things were updated annually. We are seeing things updated daily. Now is the time to innovate and demonstrate value where we are being paid parity. So we don't know where that whole parity payment is going to end up, right? We do feel we're going to be paid for more services than we were, but now is the time when you're receiving the reimbursement in a fee-for-service kind of model to do some innovative, projects, programs, and see what happens, and then document and report out on the values that you found, because that's what they're going to be looking at. One webinar I was on with some senators is that the Biden administration is going to be looking for data that supports that telehealth really is impacting quality and cost. Build telehealth into your compliance activities. We just talked about that. Make sure that that's discussed and part of your education, your risk analysis, anything that's in your compliance plan. Make sure telehealth is built into that. The two areas that we talked about, privacy and security, and then prescribing restrictions, those are the two we think are most likely going to return back to a more restrictive state at the end of the public health emergency. Michelle, what are your thoughts around that?
I agree. I think, when we see things like FaceTime being allowed right now because of, some of these waivers, video platforms such as FaceTime or just standard, video calls. I don't think, and we're definitely seeing indications that that's not going to be the case in the future. And I think universally, if you ask anyone in the telehealth space, if you're doing visits and back falling to just an audio call from a video visit, we definitely think, or even just doing it as a FaceTime call, that's just not, no one universally in the industry is thinking that's a good idea long-term, nor do we think that will be reimbursed for long-term, at least on the higher side. So I know that payers are really starting to think and want to critique phone calls in particularly when there are complex issues that are coming up as part of that visit, and then it is defined as an audio call. I know I spoke to a payer recently who said, how can we do a 99214 over the phone? There's not an ability to evaluate that patient, et cetera. So, they're definitely looking at the complexity of the visit and whether or not that was a visit that should have been done by audio or should be done by video. And certainly from a HIPAA and privacy perspective, we're not going to see FaceTime or these other types of non-HIPAA compliant softwares be available. And I'll just add, going back to your point, Christy, about policies and procedures and making sure those are up to date. I think this is such a key point. I know sometimes folks will think, well, we've covered ourselves. It's the same as standard medicine. And so we've got a standard medicine policy, and that's true, but you need to make sure that you've included some element of telehealth in there. We know that there are audits being done of that. And I would say it's on both sides. Make sure your policies aren't too restrictive. I know there have been cases where people have put start and stop times in a particular visit type where it normally would not have been required. And when it was audited, all of those claims did not have start and stop times. And so we saw the OIG come back and say, you know what, we're going to take that money back because you actually didn't follow your own policies and procedures. So make your policy simple in that it includes a telehealth piece in your regular standard clinical services, but also make sure when you're doing that you haven't inadvertently required something in that policy and procedure that you wouldn't normally need for even an in-person visit, for example. So a couple of things there. These are these nuances that are happening with telehealth, which is interesting because we do need really a best practice when it comes to some of the telehealth space work. So we're certainly working on that at Blue Cirrus. I know there's other organizations that are as well, and we're trying to follow suit with some of those larger organizations like the NQF that are trying to do more quality-based best practices, as well as the ATA.
That was great, Michelle. That's really, those are key points and things that I've experienced. So the last takeaway is that COVID advanced the adoption of telehealth. A memorable moment for me, of many memorable moments in last year, was a group of clinical providers who had really been grappling with strategy and working to convince their organization that, telehealth strategy was important and we needed to do it to move forward. And then COVID hit, and it's like, well, that just wrapped up our strategy. So COVID really has been that one driver that advanced the adoption. So it was something that was, unprecedented, unplanned, scary. Something came out of it that needed to happen, and I'm happy that did. So, but although changes are still on the horizon, it's here to stay. So I, have talked with many who felt, oh, it's just going to go back to where it was. I really do not think that is the case. It's here to stay. Organizations across the board need to prepare for the transformed landscape. So the last slide here is, how can you do that? And there's so much information out there, right? So these are some of the sites that I go to regularly that I think are the most comprehensive sites. There's so much information out there, but these main sites here really are comprehensive, up to date, and will maybe lead you if there's other information you need out from them. So this is just for your, for you to have their links right to the sites. I would recommend checking them regularly, within your organization, just to get a pulse, keep that pulse on what's happening. So if there was anything that, I would really stress, it's that keep up with it, please. There's so much changing so quickly, and it's important that we all try to, figure this out and get it right moving forward. So that's all I have. Are there any questions, Michelle?
We do. We have several questions in the chat. Thank you so much, Christy. I think that was great information, and coupled with all of the other webinars that we've done throughout the pandemic and beyond, that's really great information, excuse me, for folks to know exactly how to think about their telehealth programs. And I wanted to make a comment. You said, that it's kind of here to stay. And I certainly agree with that. Most everyone in the telehealth industry agrees that it's here to stay, but I'll clarify that as it needs to be part of an integrated clinical program. It's not just a replacement for a convenience for a patient not to drive. That's certainly a benefit. We don't discount that as a benefit, but it's part of the clinical program that you're defining for your patient. So you might say, well, we're going to do an in-person visit at this point, but then the next 3 visits will be telehealth because we're able to accomplish those same those same services via telehealth. And that allows us actually to stay more close to the patient because we typically see them no-shows with those visits, for example. So it's part of a clinical program, not just as a replacement for a physician visit. So keep in mind how that will go. And typically across the country, what we're seeing, and I think you're seeing this too, Christy, is somewhere around 25 to 30% of the visits are landing as telehealth versus what we saw, right at the beginning of the pandemic, which was something like 70, 80, 90% were telehealth at that point. Now that we're starting to get used to it, it's really kind of leveling off at about 25 to 30%.
Yeah, that is very true. And to piggyback on that, Michelle, is, so patient convenience, right, is there. That's going to be one driver of this moving forward, but it's definitely not going to be the only selling point. It's not going to be the magic key, but when you're looking at building your telehealth strategy and the services that you are going to provide via telehealth, what are those areas that are challenging, but that can be done via telehealth? So something I know some groups have looked at is putting in a no-show visit strategy and following up with patients who didn't show. A lot of them are willing to go ahead and, when they contact them, willing to do a visit then and there, and it's really reducing no-shows. And transition of care services, right? Getting patients in, it's sometimes they've got multiple providers to go to, and they'll pick one. But doing that transition of care service, even if it's by the phone, that's to get them scheduled for something next. That's better than nothing. So those are just a couple of examples.
Exactly. So we do have a couple of questions. We had one question about whether or not the webinar would be available to watch. Would it be recorded? And it is being recorded, so it will be on the Blue Sierra's website within a day or two. You should see a link up there, and you can re-watch the webinar if you were able to stay the entire time, or if you only saw a certain part and you wanted to re-watch it, you could certainly do that as well. Another question for you, Christy, is it seems like some of the possible regulatory changes would have a differential effect on third-party telemedicine vendors, especially given their direct-to-consumer and self-funded plan contracts, versus a brick-and-mortar practice. If a brick-and-mortar practice added those telehealth services, for example. Any thoughts on how that's going to play out? And I had to reread this question a couple of times, but I think what this person is asking is, it looks like a lot of the regulation is targeted at a direct-to-consumer solution where they're running a business per se as part of their telehealth, as part of a telehealth solution, versus standard brick-and-mortar providers, and whether or not that's going to play out differently. In other words, be more harsh for-profit companies that are providing telehealth services versus providers. And I say more harsh, meaning more regulation on those companies versus those that are established brick and mortar hospital systems or providers in the area.
Right. So that's a very interesting question. And it's got me thinking right now about where, that's going to go. I think it's interesting to see the dynamics, how the dynamics shifted quickly, right? Telehealth was kind of dominated by just independent for-profit organizations that they were just running a telehealth service. And that shifted now, and it's becoming integrated into a whole health system's care delivery, strategy. I believe there's going to be regulations around both. I don't know if there's going to be different regulations for each. I think there's just going to be a shift in the way that these companies work together. I think these independent telehealth companies that are doing more just on their own, that actually works to fragment our care still, versus being part of a clinically, a network that provides in-person and telehealth as an enhancement versus a full replacement. And so I can tell you that I think that the healthcare organizations are going to push for really going away from promoting these independent companies. So I think we're going to see a shift in that, because those independent companies are out there, right? And I think there may be some regulation targeted at them, because they're kind of, it's a, I don't want to say it's a free for all, but it seems like it's a new concept to have these kind of independent services. So I don't have an answer for that, but I think it's going to be interesting to see how it plays out. And we've already started to see some interesting dynamics in that space.
Yeah, I agree with that. And I would add that I think some of the compression that we see in the market, where we see some of the larger telehealth companies sort of gobbling up some of the smaller ones, or consolidating services around one company where they have both, DTC and remote patient monitoring and other types of telecart type of things going on. So they're trying to sort of ring fence all the services around. We might see some regulation around some monopolies that might be happening within those gobbling ups that might be happening with some of these larger companies. I also think that we'll see some state regulation. We know that states like Oklahoma, for example, have been very strict around DTC companies and establishing patient visits with a telehealth visit, establishing a patient with a telehealth visit. That's directly related to some operations that have happened by DTC companies in the state of Oklahoma. That's also true in some other states, including my state of South Carolina, where we're not really liking, the government, the medical boards really want to protect the patients and make sure that visits are established by by face-to-face visits, although that is relaxing some because some of the payers are obviously putting some DTC out there. So I agree. I think we'll see some states acting in that. I don't know that we'll see federal regulation, but we may in terms of the way that they're monopolizing care in some cases, especially since we see, Amazon's recent announcement with the e-prescribing and telehealth visits that they're going to be allowing, and that's only going to continue to move forward. So companies like that will really be able to do some gobbling up if they're really unchained.
I think, that brings a great point, and I know we're almost at time, but I want to mention that, these companies that are kind of almost startups, right? That are just doing telehealth, I think that might be viewed as, whether it's legit or not, as more ripe for fraud.
Mm-hmm.
And so I think you may see some more focus on those companies from the regulation, regulating bodies. Whereas, providers who have been establishing care, they're just extending, a business that they've already been in, right? And although fraud may occur, the propensity for that may not be as much as it is in some of these startups where they're, everyone's joining on the bandwagon because it looks like it's a great way to make money.
Yes, exactly. I think we'll see some regulation as well around how do they work together, how do those companies provide the best quality of care? And I don't think that's a bad thing. One thing, there's a typo here on my email address. My name is Hager. So just if you want to email me, that's michelle.hager@bluecirrus.com. And then Christy Musser did a wonderful job today. She's a great consultant on our team. We really appreciate you doing this work on this webinar, Christy. It was great, informative information. Thank you to everybody who attended the webinar today. It will be recorded on our website, as I mentioned. We will have another webinar, I think at the end of April, beginning of May. So we'll have a date there. Please follow us on Twitter, LinkedIn, and Facebook. We're always sharing great articles and information, as well as on our website. Thank you so much, everyone. Thank you, Christy.
Thank you, everybody. I appreciate your time.